For those of you who I haven't met before, I'm Brodie. I'm the Marketing and Communications Coordinator at the Hobart Hospital Research Foundation. And we're a charity that supports innovative medical research and improved projects for health and wellbeing for all Tasmania. Another organisation that aligns with our values and works towards the same goals is Simply Health. And this is a wonderful new space, and we're really happy to be moving our Research Matters events into this area. They explore and understand the health issues that impact our community, and we're really happy to be partnering with them on this event. Now, one of the biggest health conditions that affects the health and wellbeing of our community is heart disease. Tasmania has the highest heart disease prevalence of any state in Australia, and with more than 37,000 of us living with it, it's also the leading cause of death in our state. To shed some light on this, we've got Dr. Andrew Black. Now, Dr. Andrew Black is a specialist at the Royal Hobart Hospital. He's also a visiting specialist at the Hobart Private. Andrew has a particular interest in improving systems of care for Tasmanian cardiac patients and is the clinical lead for Tasmanian STMI network, the Tasmanian principal investigator for the Victorian and Australian cardiac outcome registries, and he's also a senior clinical lecturer with the University of Tasmania. He's a PhD candidate with the Menzies Institute of Medical Research and the Royal Australian College of Physicians. Not an overachiever or anything, are you? Now that we've done the introductions, let's get into the actual conversation for today. And let's learn a little bit more about hearts on World Heart Day. Now, Andrew, what are the main causes of heart disease?
Okay, well thanks for everyone's interest in the topic today. So the main causes of heart disease, I guess we think about the traditional risk factors, which are basically family history, high blood pressure, high cholesterol, diabetes and smoking. And not everyone will have those risk factors, so you see people with all those risk factors who are 80 and completely fit and well, fortunately, and you also see people unfortunately sometimes in their 20s have heart attacks that have no risk factors at all, which is devastating. But in general, the more of those risk factors you have, the higher the chances are of having some sort of cardiovascular event over time. And whilst there's ways of fine-tuning risk, there's things like scanning coronary arteries to look for early disease, there's blood tests looking at other markers of risk. A lot of the time, particularly at the Royal, when we sit in the clinics there, the risk is really very obvious. So particularly if we've got people who are active smokers, there's people with very high cholesterol or very elevated blood pressure, and those risk factors are actually pretty obvious to us. I think we come back to heart checks and we might come back to the importance of those individual ones, but basically the risk factors are additive. So if you have two, your risk is a lot higher than just having one. So that's basically the traditional risk factors. But then there's other factors that we don't really understand, and we probably put them into the bad luck component over time. And an example of an emerging risk factor would be exposure to bushfire smoke. So Faye Johnson's leading a group at the Menzies that's done some really good work showing that your risk of cardiovascular events is elevated early and also late after significant bushfire smoke exposures. So there's probably a whole lot of environmental risks that we don't sort of completely understand yet that will emerge over the next 10 years and is the subject of research.
Okay. And so with our genetics and family history, how do they play a part in heart disease?
Yep, so genetics and family history are super important, and you often see, we often see in the Royal, unfortunately, families where many relatives have had events in their 40s in particular and 50s, which is pretty early, and a lot of that is driven by genetics, but it's manifested through a high cholesterol level. So in a lot of those cases, probably the majority, what you'll see is that people have a genetically set very high cholesterol level. So what happens with this condition called familial hypercholesterolemia is that the receptors that normally clear cholesterol from the liver don't work properly. And so you basically build up a whole lot of cholesterol in your system, which puts you at a risk of heart attack or stroke by the age of 50 of as high as 50%. It's very, very high. And then people check the cholesterol maybe in their 20s or 30s when they're thinking about insurance medicals. Their cholesterol is very high, but they don't have any other risk factors, so we kind of ignore it. Whereas in fact, if your cholesterol is very elevated, the numbers to remember, if your total is more than about 7, or your LDL cholesterol, the bad cholesterol, if that's more than 5, regardless of other risk factors, that's actually a significant problem in itself, and it's absolutely worth treating. And the good news with that is that if you pick it up and treat it early, and there's evidence for treatment even as young as age 8, so there's nothing controversial about that, that's very evidence-based. If you treat people from an early age, it completely removes that risk. So you go from being very, very high risk to actually having a risk that's below the population average. So, so when you see families where there's a lot of cardiovascular disease, particularly blocked up arteries, heart attack type events, usually what you'll find is there's a very high cholesterol history that runs through there. So that's I've gone on about that, but it's a particular focus. It's something that I had zero interest in 10 years ago, and then after putting stents in the same situation over and over again, you might find that the only history when someone comes in with a big heart attack is 10 years worth of Hobart pathology results showing a cholesterol of 9, 9.5, 8.5, 9. And you see the same thing again and again and think, well, actually maybe this is something we really need to focus on, and that'll be the subject of more research going forwards. Research as in not to work out what the problem is, we know what the problem is and how to treat it, but actually the implementation thing of how do we stop that happening. So that's the main genetic issue.
Okay.
The inheritance, I should say, as well, is about 50-50. So for people who think they might have this condition, the chance of their offspring or brothers and sisters having the same condition is about 50%. And again, there's nothing to be scared of. They can get their cholesterol checked. If it's normal or a bit higher, like 5.5, like lots of people, that's not a big deal. They probably just don't have the same condition. And if it's really high, if it's elevated at those levels, above 7 as a total, then they probably do have that condition and it's worth treating.
Yeah. I had high blood pressure, high cholesterol on my last blood test, so I will be going.
Excellent. Yep. Easy fixes.
I just was taking notes as you were talking. So, what are the main symptoms of heart disease?
Okay, so this is super hard. I mean, the classic symptom is tightness across the chest, radiating up into the jaw and down the left arm. But gee, people present with all sorts of things. We've seen people who've had teeth extracted because the pain's just in their jaw, and then it turns out they've had angina. There's people get pain up the back of their neck. There's one study that suggests that pain down the right arm might actually be quite specific for heart disease. So I think, it's super hard. I think the message is if you have any new symptoms anywhere around the chest that you're concerned about, then it's really worth getting it looked into. We run a rapid access chest pain clinic at the Royal. We've seen about 6,000 patients there now since 2014. About 95% of people that present with chest symptoms to that sort of service are fine. So it's not heart related, everything's okay. We're very happy to see all those people. We just make sure everything's okay. It's not a big resource utilisation. But what we do want to make sure is we see enough people that 1 in 20 that have serious issues that we get onto them quickly so that we can try and put in strategies to prevent events happening. So the only thing that I think it's safe to say that you can probably ignore is we see people who have, for example, 1 or 2 second quick twinge that's very focal. There's a lot of that symptom around, and that's pretty much always going to be muscle or joint related. If you can pinpoint it with your finger and say that's right there and it's gone within a second, it's really hard to imagine that's got a cardiac basis to it. But if there's something new across the chest, it's probably worth getting looked into. And in particular, if it's got an exertional component, if you find that mowing the lawn's the typical one, mowing the lawn's fine, and then all of a sudden when you're pushing the mower you get a bit tight in the chest and it takes you 2 hours to do what used to take you 20 minutes, that's reasonably likely to be angina. But of course the problem is heart attacks are unstable sudden changes, so that's not going to follow that pattern of mowing the lawn. That's something that just happens suddenly. So if you're sitting there with chest pain and you're wondering about whether to call an ambulance, you're probably better to do it and come in. And if everything's okay, that's fine. You're just like the majority of other people where everything's okay. No judgment, you can go home and get on with things. And an ambulance is the right way to come in. So we do see people every year, unfortunately, who will drive themselves and might have a cardiac arrest on the way in, which is untidy. So ambulance is the way to go because they can keep you safe, obviously, if anything does happen.
Untidy.
Yes.
Okay. All right. Well,
just a question on the rapid access.
Yeah.
Is that a lane or a stream when you go into emergency? Is that?
Oh, right. Yeah, sure. So basically what happens is the emergency department role, it's a good question, will be to rule out heart attacks. So we often see people in the clinic and they'll say, they didn't do anything. And they did, because they're ruling out a heart attack. They're making sure you don't need to come into hospital and have something done straight away. their rule-out tests, blood tests and things will make it, somewhat unlikely there's a significant cardiac issue going on, but not for sure, and it probably keeps you safe for the next 30 days. So then we'll see a lot of those patients as follow-up in the rapid access clinic. So basically within 2 weeks of discharge, they'll be offered an appointment in the Wellington Centre, and then we'll run through the story with them. And sometimes it's really obvious we don't need to do anything else. They might have been to the GP since then and they've actually got a sore shoulder because they lifted something funny, and then we'll do nothing. But if we're not sure, we'll do some kind of additional testing like a scan or an exercise test. So it's an outpatient service.
Right.
Yeah.
All right, so thanks for that, Andrew. We'll move into assessments. So if we do start having these symptoms, when should we see a doctor?
So yes, I guess kind of similar to what we were saying there. So I think if you have chest pain, hopefully no one has chest pain right now, but if you have chest pain come on right now, that goes on for more than a few minutes, and particularly if you're feeling at all unwell with it or you're not sure, that's an emergency department thing, because that could be a heart attack. It's probably not, but it could be, so you're better off getting it seen to. If you're having bits and pieces of chest tightness that come on when you're really pushing yourself, walking up a hill, that sort of thing, that's worth seeing your GP and getting a referral to somewhere like the chest pain clinic. So there's private cardiology groups, there's a chest pain clinic at Calvary now, and there's also one at the Royal. So that's probably the pathway. But anything, I get calls not infrequently from, friends or friends of friends or relatives saying, I've got chest pain, what do you think I should do? And the answer is always to go to the emergency department. It's always the same.
And if we do go to see a doctor and we do go in to get these heart checks, what should we expect when we're actually having this done?
Sure. So heart checks, it depends a bit about what it's for. So if you've got symptoms, then there's a desire to see whether there's any. I'll go back a bit, I guess. If you look at, what we're talking about is a build-up of plaque in coronary arteries. So the little arteries that run around the heart that supply blood to the heart muscle itself. It's not uncommon to have some plaque in the arteries. If you've got enough plaque there that is limiting blood flow, then when you're doing things, the heart gets unhappy, you get a cramp in the heart basically, which is what angina is. So if you have symptoms, the assessment will be around trying to determine whether your symptoms are angina related to the heart or whether they're just, muscle joint related, reflux, whatever else. And the kind of things we'll do would be things like an exercise test, get you on a treadmill and see what happens. We're looking to see if there's changes on your ECG to indicate narrowed arteries. And there's different types of scans you can do, including a cardiac CT, which is a CAT scan to have a look for narrowed arteries. That's for symptoms. If you're just going for a general heart check, and we're seeing a lot more people now looking for heart checks, they might have a family history, or you see various, the high profile issues like Shane Warne has sort of triggered a desire for people to have a look and see where they're at. So if you're coming in for a general heart check, the best person to start with is your GP, and they'll do what's called an absolute risk assessment. So they will look at your traditional risk factors, they'll measure your blood pressure, cholesterol, talk to you about family history, check you don't have diabetes, and obviously smoking history. And there's a website, it's cvdcheck.org.au, so just cvdcheck.org.au, and they'll punch the numbers in there, and that will give you an idea of what the chance of a heart attack or stroke is in the next 5 years. It's a slightly gross tool, but it gives you a pretty good idea. If your risk is very, very low, you probably don't need to think about it too much more. And if your risk is very high, you probably do need to think about it, and it's probably worth being more aggressive, so lifestyle type changes and potentially medications. And if you're in that intermediate risk, then you have a discussion about whether there's other tests that might help re-stratify you. But basically it all starts with that kind of absolute risk assessment, and then there's more nuanced ways of assessing risk further from there. And again, I probably don't want to get bogged into cardiac CT at this stage, but there may be questions about that because it's a bit topical.
And that website again was cvdcheck.org.au.
That's it. Yep.
Great.
And it's a fancy new risk calculator. It's been around for a while, but they've just redone the risk calculator to try and make it more reflective of an Australian population. So it's based on the risk calculator used with a lot of success in New Zealand. Yeah.
Great. Okay, that's a very easy one for you guys to check out.
Another question, if I might.
Yeah, definitely.
In terms of you've had a diagnosis and you've done some lifestyle changes, obviously to hopefully alter your risk assessment. By doing those things, does it lessen the possible impact? Are you lessening the arteries clogging up? Can some of the bad work be undone?
Yep. So lifestyle changes. By that we're meaning, the healthy heart diet, and there's lots of information about that. Again, on that CBD check, it links to all of this information, which is quite handy because there's also a lot of really bad advice on the internet too. So the healthy heart diet, which is basically a Mediterranean type diet, and regular physical activity will absolutely reduce your risk of adverse events over time. So we know that if someone's had, as you've said, if someone's had some sort of cardiac event, a heart attack or a stent, the chance of another event over 5 or 10 years is in the order of about 5 to 10%. So it's, for an individual, it's not super high, but it's not people aren't fixed, I think is the unfortunate message. There is an ongoing risk there. And part of that is thinking, well, this event's happened, what are we going to do differently now that we weren't doing before the event happened? So the lifestyle changes are really important. They definitely do lower your risk over time, and even things like cardiac rehab. So if you attend a cardiac rehab program, they talk about all this lifestyle stuff to take you through it. Your chance of dying of a heart attack over time is less. So there's actually a really hard endpoint that is favourably affected by going to cardiac rehab. Statins, I guess, is the other really important thing to mention here too. So statins reduce everyone's risk of cardiovascular events. So if you treat your bad cholesterol, your LDL, with a statin, or anything for that matter, but statins are sort of the first line thing that bring it down the most. If you lower that number by 1 millimole per litre, which is super easy to do, you lower your risk of adverse events over 5 years by 20%, and over 20 years you reduce it by 50%. So we're not looking for a cure here, we already know what it is. So we push the cholesterol really low, we substantially alter the prognosis of patients with vascular disease. Do you get rid of the plaque, which is sort of where you're getting to, which is what everyone wants to know. Can you flush this plaque out? Sort of. So there's nice studies coming out of Japan that looks at the type of plaque you've got in your arteries. So if you've got untreated coronary disease, a lot of people will present initially with really fatty, inflamed plaques in their vessels. And now that we've got really nice imaging tools like CT and also OCT, which is like a camera we can stick down people's coronaries, you can tell what type of plaque they have there. So fatty, inflamed plaque is much more likely to progress and change. It's more likely to break open and cause a heart attack. Whereas fibrous calcified plaque is much more likely to stay stable over time. So if you put people, there was a Japanese study where they had people on statins or not on statins. It wasn't a randomised trial because it's not ethical to not treat people with statins, but there's enough people who've read enough on the internet, they've decided not to take statins, so they make up the control arm, which is kind of handy from a research perspective. And basically what happens in the control arm is that plaque just gradually gets worse over time, as you'd expect. In the treatment arm, and this is just statins, it's nothing fancy, that plaque tends to reduce in volume just by a little bit, so a couple of % per year. So it doesn't flush it out, but it does reduce it a little bit. But really importantly, it changes the type of plaque from an inflamed fatty plaque to a nice fibrous calcified plaque. So it really, that's what you don't want, is a big inflamed plaque suddenly changing, because that's what causes drama. Yeah.
So can that alter your calcium score over time?
Yeah.
That if you get calcified plaque, your calcium score
yes
goes up?
Yeah, so that's an awesome question, and I'm sure there's some cardiologists don't completely understand this. So calcium score, interestingly, what will happen then is your calcium score will go up. So what we're talking about is if you've got plaque in your arteries, you will tend to deposit calcium in that plaque over time. And so if we meet someone for the first time, don't know anything about them, and we want to know whether they've got some atherosclerosis, some plaque, we might do a calcium score, which is a really simple way of just saying, how much calcium's there. And then you can compare it to other people, your age and sex, to see whether you're at high risk or low risk or whatever else. Once we know someone's got vascular disease, either through a calcium score or having an event, we shouldn't do a calcium score again, because actually as the plaque stabilises, it does calcify and your calcium score will go up, and that's a marker actually of stability of the plaque. So sometimes you'll see people having serial calcium scoring. I really don't find that useful, and the major guidelines would recommend against doing it, because what you'll see is the calcium score goes up. And actually I saw someone just recently who'd had bypass surgery in the past, so they definitely had established coronary disease, and they had a CAT scan for another reason, and someone had commented that there was a lot of coronary calcification, which created a bit of stress, but actually it just tells you that there's plaque there, which we knew about, and that it's probably stabilised over time. So Yeah, so that's a really great question about calcium scoring. Yeah.
It's all right. We've jumped around a little bit from our format, but that's great. So we've moved into the treatment area where we've, by changing our diet and lifestyle to treat our heart disease once we've already got it. Does that work?
Yeah.
It's
probably worth, if I can just sort of mention lifestyle, because the term lifestyle is really difficult, and it often comes across as a bit judgy, like someone gets to 18 and they decide they're going to go out of the way to adopt an unhealthy lifestyle and develop cardiovascular disease because they're a bad person. And I think that's part of the problem around the, getting interest in things like treating cholesterol. This person's cholesterol is high because they eat rubbish all the time. And in fact, particularly with cholesterol, when people have a very high cholesterol, it's usually a genetically set thing. They're not clearing it. So it's really got little to do with what they're eating and a lot more to do with how their liver's not clearing cholesterol. And we know that lifestyle factors are obviously very heavily influenced by the environment that people live in. If you live around people that smoke, you're more likely to smoke. If you live next to a highway, you're less likely to get adequate physical activity. You're more likely to have a heart attack over time. So, obviously the type of food you eat as well. If you have a lower income, you've got less access to fresh fruit and vegetables. You're going to be more likely to eat highly processed, cheap food. So again, that's where the whole public health side of this comes in. And I think it's one of the problems that we have with managing cardiovascular risk is there's often this implied blame of the patient where, you certainly see some people who've done a bit more to earn their cardiovascular disease, but there's certainly no one that deserves it.
Yeah, interesting. So if lifestyle changes alone don't work, what are the types of medications that people have to help them with their different types of heart conditions?
Sure. So, don't want to be accused of being a rep for Big Pharma here, but statins, it's all about statins. When we talk about lowering cardiovascular risk, it really is, for established vascular disease, that's the number one thing to stabilise plaque and reduce progression. Treatment of blood pressure is really important as well. Blood pressure, unlike cholesterol, blood pressure will respond much better to lifestyle interventions, regular exercise, weight management makes a big difference. So for someone who might be quite overweight, it's not about achieving a normal weight, but even losing 3 or 4 kilos might knock 5, even more millimetres of mercury off your blood pressure. So you can take a tablet, might drop it by 2 or 3. Doesn't do as much as you think. It does when you stack them all together, so we still need to do that, but actually weight management and exercise does a lot. Salt restriction is really important for blood pressure management as well if you've got established high blood pressure. And then medications, it's probably worth mentioning aspirin as well, because that's sort of been interesting. So aspirin for prevention, it's really interesting that there's been so many randomised trials now that have shown no benefit in aspirin from a purely preventive point of view. And so these studies come out about every 2 or 3 years, and then the media runs a big article saying that aspirin doesn't work, and then everyone stops their aspirin. But of course, aspirin works and is really important if you've got significant established vascular disease. So if you've had a heart attack, aspirin does lower your risk. If you've got a stent, it's actually critically important to be on aspirin because it stops clots forming in the stent. That's different to just taking an aspirin to try and reduce risk, because it probably doesn't reduce your risk, for the average primary prevention person who hasn't had an event before. Or if it does reduce your risk, it probably does it by so little that it's about the same as the offset in terms of bleeding risk. So your risk of major bleeding is about 1.5% a year on aspirin. So aspirin purely for prevention is out. I think that's sort of the main things.
Okay, great. So failing both of those interventions, what type of surgery is available, and what kind of conditions does that treat?
Sure. So surgical things, I guess we'll put stents in that as well. It's sort of an interventional physician specialty, but we'll call it surgery because it feels like that. So if people have significantly narrowed arteries that are limiting blood flow, they might benefit from having stents put in, like little metal cages in the coronary arteries to open them up and get blood flow through there. Who benefits from that is not as obvious as you'd think. So I think we used to think if there was a severe narrowing, you put a stent in and it prevents heart attack, but that's definitely not always correct. If someone's having a heart attack, so the people that come into the Royal by ambulance come straight through the emergency department and up to the cath lab with an occluded vessel. If you open that vessel up with a stent, that's definitely got a mortality benefit. So that's a life-saving procedure. People are more likely to survive, less likely to have other bad things happen to them. So that's important. If someone comes in with a small heart attack or a threatened heart attack, they're less likely to go on and have a major heart attack, and they're also more likely to survive in the longer term if you open their vessel up with a stent. If you've got stable symptoms, most trials will suggest minimal to no benefit with putting stents in. And that kind of makes sense, I guess, because if you've got a big lipid-filled, nasty, inflamed plaque that's suddenly ruptured open, and is limiting blood flow at rest, it kind of makes sense that scaffolding that open is going to help. But if you've got a very stable plaque that's been progressing over 20 years, is causing symptoms but hasn't caused a heart attack, going and tearing it open basically with balloons and dropping stents in there is of uncertain benefit in some groups. So there was a study published about 18 months ago where they did it's like a sham procedure, sham controlled trial. So they took people into the cath lab, they put sheaths in everyone's arteries, and half the patients they put stents in and half they didn't, and then followed everyone up, and the patients didn't know whether they had a stent or not. And then at follow-up, there was no difference in anything, adverse events, symptom control, or anything between the two groups. The thing with research stuff is you've always got to then look at how that applies to your patient population. So in that study, the average participant could do 9 minutes on an accelerated Bruce protocol, which is on a treadmill at a reasonable incline going reasonably fast by 9 minutes. And there would be no one would get anywhere near the cath lab at the Royal Hobart that could do 9 minutes on a treadmill, I don't think. So you probably, there's nuances. If you've got a very tight narrowing in a very big artery supplying a large territory, I think most people would argue there probably is a benefit in having that fixed up in terms of prognosis. Certainly in terms of symptom control, there probably is. But we always need to be a little bit careful that we're not putting stents in people who don't definitely benefit from them. And so there's more of a move now to make sure that rather than people going straight to the cath lab, unless they're having a heart attack, obviously, that they have things like stress tests or other scans to see where they're at, rather than just going and having a look. And the worst scenario would be that you go and have a look and stent something, and then the symptoms continue, and it turns out it was reflux. It's got nothing to do with the heart. And that definitely used to happen, but it probably doesn't happen so much now. So that's stents. If you've got more extensive coronary disease, so if there's a whole lot of plaque in the arteries, rather than putting stents all over the place, you're probably better off starting again with a new circuit, and that's where people tend to have bypass surgery. So there is that discussion between the two options, and we've got quite a nice statewide meeting run out of the Royal here to discuss with all the cardiologists and the cardiothoracic surgeons what the best strategy is for people that have got fairly advanced coronary disease. And again, that's about reducing that risk in the long term, 10, 20 years, rather than thinking immediate benefit. And then, there's operations, I guess, for people with valve problems and fancy pacemakers and things as well. So there's any number of procedures. I wonder if, I'll mention that later. That's okay. We'll come back to it.
Yeah, no worries. Well, I'm glad I haven't been given a stent for my reflux.
Yes.
Gosh, that sounds terrifying. So technology is changing all the time. What are some of the new groundbreaking developments that you're seeing, and some of the things that have happened, I suppose, in your time as a surgeon?
So probably the main change that's happened in Hobart here in the last 5 or 6 years is the introduction of more structural interventions. So a lot of the interventional work we do is stents, coronary stents, which do work really well for lots of people. I shouldn't, I put stents in, I shouldn't bag it too much. We've just got to be careful who we stent, that's all. But you can also now deal with things like valve problems. So aortic stenosis is a really big problem as people age. So the aortic valve sits at the top of the heart and basically can become narrowed over time. So it tends to be a reasonably slow process occurring over many years. And as it becomes very tightly narrowed, people get breathless, and eventually it's a fatal condition if it's left completely untreated. The problem we used to have is that the only treatment option we had was open heart surgery to replace the valve, which is a little bit tedious if you're in your 40s and 50s, but it's quite tedious if you're 85. And so we now have pretty good access to percutaneous valve replacements. So this is led by Heath Adams, who's in charge of the structural intervention team at the Royal, and Bill Martin, who's just moved back from London. He's also doing tabbies with Heath, these procedures. And it's basically done under local anaesthetic. It's an awesome procedure. They have the valve crimped on a cage, a bit like a stent, goes up through the artery in the leg, up to the top of the heart, inflate that in the old dodgy valve, just squashes it up against the wall of the vessel, and it's sorted out. There's a risk of serious complications of about 1 or 2%, which unfortunately does happen, but it's relatively low. And the patients can go home the next day, which is great. And if I think back to the last quite elderly lady that I sent for valve surgery. This was just a little bit before the structural intervention program started. She was about 85, but quite frail, quite little, sitting in the chair. And I remember just looking at her the day she was going off for surgery, thinking this is just such a brutal thing to do to someone who's very frail and quite elderly. And so this, this percutaneous stuff is really fantastic. So initially, the indication for that was people who were inoperable because they were otherwise very unwell, wouldn't be likely to survive surgery. And then of course the indication creeps down, so age over 80, we can now sort of sneak people through probably 77, 78, and that'll probably gradually continue. You've got to consider the lifespan of that valve, so you don't necessarily want to routinely be putting these in 40-year-olds, but it's a really useful option for people. And again, being able to do it here is great, because even sending people over to Melbourne for this type of valve stuff was again a bit of an issue for some people who might not do a lot of travel or mobility is limited and things. So that's a big change. And I guess the other thing that chews up a lot of our cath lab time is Jonathan Lipton's EP service, so for heart rhythm issues. Things like atrial fibrillation, probably a lot of people have heard about, heart rhythm irregularities. There's lots of medications that you can use to try and control that. There's lifestyle measures as well. But if all of that fails, then there is EP procedures where you can, again, put catheters up through the vein in the leg and put a burn using radio frequency around the part of the heart that this rhythm disturbance comes from. And we had no EP service here up until, I think, about 6 or 7 years ago. And now the cath lab is just chock full of EP procedures. And it gives the stent people a bit of time off the cath lab, which is quite nice. And that's a statewide service, so it supplies a service to the north of the state. So Jono's the only EP cardiologist. He's super busy, and we do have an interventional fellow here now, an EP fellow, Josh Horson, and he will probably come back and work with Jono to support that service. So there's lots of fancy ways of sneaking things into the heart without causing this, which is good. Although this is fine if you need it. But.
Right.
Yeah.
I just had 3 stents put in 2 weeks ago.
Yep.
It was interesting that 3 of the doctors there mentioned that it was most probably caused by the radiation treatment that I had for breast cancer.
Yep.
Which surprised me.
Yeah.
Also, I just might ask, recovery time from that. I was expecting to be jumping through hoops, but I'm not. Should I be expecting to wait a bit longer, or?
So the radiation treatment's a really interesting question, and there's this whole notion of survivorship after treatment for cancer, and my wife's a medical oncologist at the Royal and has been quite involved in this. So we know that there's a lot of cancer treatments like chemotherapy and radiotherapy for sure that can increase the risk of vascular disease over time, and more people are surviving their malignancy now, and actually the biggest threat to them is then cardiovascular disease in the longer term. So there's a much greater focus on looking for this and just being aware of that possibility over time. So yeah, unfortunately, there's a good chance it probably is related to the radiotherapy. Having said that, that's okay. It's all treated the same. Stents, it depends a little bit on the setting. Often you would expect to bounce back very quickly after stenting. So that's, I'll be around. I'm certainly happy to have a chat about what the best way forward is after we're done. But yeah, in general, depending on the setting, if it's an elective thing, often people feel heaps better the next day. If someone's had an event and there's any damage done, it might take several weeks of feeling, being a bit washed out and then gradually getting better. But yeah, usually the recovery time's pretty quick, which is the advantage over surgery. Yeah. And I guess the message is for people that have had cancer treatment is just again to be particularly aware of those risk factors, things like cholesterol, having a lower threshold for treating that, watching your blood pressure, obviously not smoking, that sort of stuff.
Nothing, it was never mentioned. It was actually quite a surprise to me that it was never mentioned at all.
Yeah, I don't think, I'm not sure how long ago it was, but I don't think it was widely recognised. It's really only become properly recognised in the last
4 years.
4 years ago is not very long ago. Yeah. But it's definitely an emerging specialty, and in fact, there's a whole specialty, cardio-oncology now, where people are specialising in cardiac aspects of oncology treatment, which is a specialty that hopefully we'll have at some stage, but don't have yet. So we've got the next best thing, which is a oncologist who's married to a cardiologist.
All right. Well, Andrew, we'll move into looking ahead now. So there's lots of exciting heart research taking place at the university, in Tasmania. Can you tell us a little bit more about the new projects that are going on in the laboratories at the University of Tasmania?
Sure.
And I'll get out of the way here.
Okay, so ta-da! This is the Menzies flagship, which I'm aware of, but I'm certainly not leading. This is being led by a group of researchers, high-level researchers at the Menzies. When I first heard about this, I was wondering, how much actual impact this will have on the ground, and in actual fact, it's very exciting. So I think the whole aim of this Menzies flagship, which is being launched on the 1st of December, is to try and encourage or promote research that has a really translational aspect to it, and that's something I'm really interested in, because we see a lot of money put into really big clinical trials looking for new treatments, and cholesterol is a really good example where we've got very expensive treatments that are 3rd and 4th line agents, and it's really fantastic to have those, but they might be $7,000 or $8,000 a year cost to the PBS. And we know that there's people wandering around all over the place who should just be on statins who aren't, or should be on a higher dose of statins who aren't, or who we could help stop smoking and we don't, or there's other conditions that we could recognise better and we don't. So we've got emerging treatments which are really fantastic for people that really need them, but we've also got a lot of very established treatments that work really well that we underutilise. So that's a lot of what the flagship's about, is about having really translational research that actually gives a fairly significant impact to the overall health burden of vascular disease in Tassie, which incidentally has the highest rate of vascular disease in the country, pretty much up there with Northern Territory. And it's not a northwest problem, it's just as bad in non-central southern Tasmania as well, so it's a real problem. I guess there's a couple of areas of particular research. I've probably banged on about lipids a lot because that's my thing, so I'll give that a miss now. So Shauna Gall leads a group looking at stroke prevention research, and so her areas around digital health interventions. I had to write that down so I remembered it correctly. So they're setting up an open online course which is around training people or teaching people how to recognise signs of things like atrial fibrillation and irregular heart rhythm that can increase the risk of stroke. So I was trying to get that message out there that this is the kind of thing people could be looking for, and then using things like blood thinners to reduce that risk. Jim Sharman leads the Menzies blood pressure research group, which is quite a big group with a very good research track record. And the aim of that research work, which we assist with in the cath lab at the Royal, is to try and improve the assessment of blood pressure. So we know, and everyone here who's probably ever measured their blood pressure knows that it's a very frustrating experience. You'll measure it and then 10 minutes later it's completely different, and then it seems to be high but you're dizzy, which suggests it's low. So our assessment of blood pressure is not very good, and so it's about trying to fine-tune devices and get better devices that give us a better idea of what blood pressure is doing. There's potentially a really exciting project coming, which is a real-time data dashboard that's in the sort of early conception phases, looking for grants, but potentially has some early support. The aim of that is to try and record in real time everyone's cardiovascular risk factors. So when you go to the GP, you have risk factors managed and it goes into Praxsoft and that's it. But it would be absolutely amazing at a state or national level to be able to sit and look at a real-time dashboard and say, right, the people who live in Oatlands, and I've just picked Oatlands because I do a clinic there, they're all great, but the people who live in Oatlands are at really high cardiovascular risk. We could be doing a lot better with smoking or with cholesterol or whatever there, or this particular practice has this issue, or maybe we need more resources in the north of the state or whatever. So that's a really potentially quite exciting project over time. That's kind of a bit of a taste of the main things, but there's a lot going on. And obviously I mentioned phase work with the bushfire smoke as well. There's a lot of really interesting work happening.
Now you're part of a foundation funded grant in 2022 with Dr. Neve Chapman, and it was a review of the rapid chest pain clinic at the Royal. How are you involved in the study and what outcomes have been implemented?
Sure. So the rapid access chest pain clinic at the Royal, we did talk about a little bit before, but the reason we set that clinic up is we were seeing a large number of people present to the emergency department with chest pain, and there's kind of disorganised follow-up. They might bounce around various clinics I followed one patient's journey when I went back through the record over 4 years. They'd had 9 clinic appointments and tests. It was just out of control. So the idea was to see people quickly, to grab the people who've got something seriously wrong with them, and then to reassure the people that don't and move them out of the clinic system so you get an answer quickly. And what we found, which is not surprising compared to a general clinic, after we reviewed the first 1,500 patients is that the patients seen in a rapid access chest pain clinic are less likely to have adverse events. So the adverse event rate at 12 months is pretty close to zero. I think it's about 0.2%. And they're much less likely to represent to the emergency department. Obviously they know what's going on, they've been sorted out, as opposed to this vague, we might see you in 6 months type thing, and people go back to emergency. So that was obviously a key goal given the system we work in, which is the same as every other public system in the country, to be honest, but we want to try and avoid unnecessary attendances to emergency. And so Neve Chapman, who's now working in Sydney, but hopefully will come back to Tassie eventually because she's pretty outstanding. She's a qualitative researcher, and basically what they were wanting to do was to do a review of that rapid access chest pain clinic and try and work out what it is that makes that clinic work, and then how can you translate that into other clinics around the country and also internationally. So RAC packs were set up in the UK many years ago with minimal evidence behind them, and now they're kind of being picked up in an ad hoc fashion around the world, and there's no clear understanding of what the best way is to do it. So does everyone have an exercise test, for example, or do they see us first and then go off and have other tests? So it was really to try and tease out what the best way is to run this, and there's a number of publications have come out of that. So that's been a good project, and the clinic's still there. We've seen about 6,000 patients now since 2014, so probably know someone that's come through RACPAC.
So can I just say, is that the clinic that's at the Wellington Centre that you meant?
Yeah. Okay. So there's the general cardiology clinic, and then we run RACPAC separately. So it's to try and remove people from that wait list issue and say, right, let's see all these people quickly, and then just kind of move them through.
All right, well, we've probably got time for only a couple of short questions from the audience, but just before we open it up, I will just say we won't answer probably specific medical advice for each individual. So if it can be general in nature, please feel free to raise your hand.
You briefly mentioned those people who looked at the internet about statins. Can you address that?
Thanks for asking. All right. Have we got 45 minutes? All right. So this started back in 2013 with the, I'll try and be brief, with the Catalyst thing. Yeah. So that was garbage. It's been completely rubbish. And actually it was really interesting. If you YouTube Heart of the Matter, which was the title of it, Heart of the Matter Catalyst Media Watch, you can usually still pretty easily find the Media Watch segment that was done the following week. And that's interesting because they look at from a journalistic standards perspective, how that was put together, and it's a savage take apart of it. Everyone watched Catalyst, no one watched Media Watch, even though it's really good. So that's quite interesting. It's been taken off their website, and there was an internal investigation, all the rest of it. So where does this all come from? And I think where it comes from is there is a risk of about 1 in 10,000 of serious muscle damage called rhabdomyolysis from statins. And so because of that, I think we've always said to people, watch out for muscle aches if you're taking statins, and you have to come back and see us if you get that. But of course, if you start people on a medication to say, watch out for muscle aches, about 30% of the population has significant muscle aches at any given time. So then there becomes this very strong association between statins and muscle problems, and therefore statins are bad. So I think that's the best answer I can come up with, because I don't understand, out of all the medications we've got, why has this group picked statins out of all things as being, this is what we're going to really go for. I guess for a while they were also the biggest individual cost to the PBS, so again it fits into the whole big pharma conspiracy thing. But if you actually just look at the numbers, so the risk reduction is dramatic with statins compared to the small risk of muscle-related side effects. There's a slightly increased risk of diabetes over time, very slight, just increases your blood sugar slightly for some people. And there's that very small risk of muscle damage. So for some people, statins are definitely not for them, and that's where having these new, more expensive treatments is absolutely fantastic, because we've got high-risk people where we had not much to offer them, and now we do. But I think that's where the statin stuff comes from. The other interesting thing is if you watch, so YouTube is where a lot of the anti-statin stuff is, and if you watch these things, which unfortunately I have, which has now destroyed my Facebook and YouTube feed, but if you watch these things right to the end from experts, they're always selling something every single time. There's none that finish and they're just there. I mean, when I go to work, I just don't want the person in front of me to have a heart attack. There's always something at the end of this, and they're always selling a vitamin or a book or a new diet or something. Every single one, it's really interesting. And it's really quite hideously unethical that happens. But the focus has really changed because there was the whole COVID thing, and that really, the same type of people I think became quite obsessed with the COVID vaccination stuff. And it's interesting now, it's what used to be a 40-minute discussion about statins is now literally a 2 or 3 minute chat. Everyone in my family has a heart attack in their 40s, my cholesterol's 12, do you think I should take a statin? Yes. Like it's literally that easy. Yeah.
Got it.
Yeah.
Thank you.
Cool. No, thank you for asking.
Anybody else got a question?
What role do beta blockers and channel blockers play in heart treatment, cardiovascular disease?
Yeah, so that's actually great questions. So beta blockers, we used to start them routinely after people had a heart attack, and that goes back to the dark days before strong clot busting medications and stents, where people just wrote out heart attacks and just wiped out whole big parts of their heart. And so it was shown, I was at school, people showed back then that beta blockers reduced their chance of dying after those sort of events. So we now sort of routinely commence them at the time of anyone having a heart attack. It turns out that as long as your heart function is normal, and you're sort of patched up and there's good flow in the coronaries, the benefit of beta blockers might actually be not so much in the long term. So we're probably not using them as much for just standard narrowed artery issues, although they're still used for blood pressure. Where they're really beneficial is if your heart function doesn't work. So we've talked about narrowed arteries, but a lot of people will have hearts where the actual pump function doesn't work so well. And the beta blockers, if you imagine the sympathetic nervous system just kind of flogging the heart to make it keep going, the beta blockers just damp that down and give the heart a chance to recover and improve function over time, and reduce the risk of sudden death in people who've got impaired heart function. Did you say calcium channel blockers as well? Is that the other one? Yeah. So calcium channel blockers probably have less of a role in heart disease specifically, but are really good blood pressure agents. Yeah. And then there's ACE inhibitors as well, are good for people with impaired heart function. So we tend to use minimal medications in people with narrowed arteries. That's all about kind of statins, aspirin, lifestyle stuff. If you've got a heart that doesn't pump normally, there's a whole variety of medications, and again some new things which is really nice, that help to improve that heart function over time.
Thanks for bringing that up. I completely forgot to take mine at the start, which is why I was so nervous. Anybody else got a question?
Only we hear about ramping of ambulances and things and how long they come and collect you when you've had asked for them. They would come if you said you've had a heart attack, or would they come to you first? And then you're obviously put in the fast lane when you arrive here.
You are, yeah.
So it's I always feel guilty. I mean, not that I've had to ask them, but you hear of these dramas of not enough ambulances or they're standing in the queue.
Yeah, so I think, I don't think you ever need to feel guilty if you've got chest pain about calling an ambulance, and be reassured that if they're happy there's not a lot going on, they will take you out of the ambulance and put you in the waiting room when you arrive at the Royal. It does happen. Yes. But if you are having a heart attack and they'll know fairly quickly, there's a really fantastic system now where they will pre-notify us in the cath lab. So if they come out, they'll do an ECG, and the paramedics do an awesome job of this. They'll generally spend 20 minutes on scene. That hasn't changed. They do a lot in 20 minutes. They'll do an ECG. If the ECG shows a big problem, like a good going heart attack, they will email that through to our email thing, which goes out to all the interventionalists and retrieval people across the state. We'll then have a conference call with retrieval. So while there's a nurse in the background coordinating your retrieval from wherever you are, we'll be having a discussion about whether we give you strong clot busting medication where you are, whether you come in by road or helicopter, and we'll clear the express lane for you with the Royal. So you basically come straight through, you don't stop, the wheels don't stop, you come straight through, go up to the cath lab. And the last case we did when I was on call last weekend, I think it was 18 minutes between arrival at the door and having the artery open with a balloon. So it's, there's a lot of
What if you're having a non-STEMI?
Non-STEMI, you'll wait, but you won't wait longer than you need to. So you'll generally get done within 24 hours. So that was a question of if you have a heart attack, like a threatened heart attack or a mild heart attack, but not a full-on. The issue is if you're having a STEMI. So if the vessel's completely occluded, that's a real drama, and you've got to get that vessel open really quickly. But yeah, you'll get looked after probably actually quicker here than most other places in the country with a big heart attack. Ambulance wise, Response times, I don't know that I can really answer that. I generally, the impression I have is that people come in very quickly. But yeah, there's always that risk, particularly if you're something like Oatlands, and that's why we've now got strong clot-busting medication at a lot of sites outside the major centres, so that if you're at Oatlands and the Oatlands crew's ramped outside the Royal and they're sending the Bridgewater crew, you can at least start treatment there, and hopefully that's sorted you out by the time you arrive. So there's a pretty good system there.
Okay.
Yeah.
So can you just spell out STEMI?
Oh, so STEMI, yeah, so it's STEMI.
Yeah.
So it's an ST elevation myocardial infarct. So what it means is that on the ECG, there's major changes on the ECG. So the ST segment goes up. And what it indicates is that one of the coronaries is completely occluded. So that's a big difference from having an almost occluded vessel. So if you've got an almost occluded vessel, it annoys your heart, it doesn't love it, but it won't kill that whole part of the heart. But it's a bit like your grass. If you don't water your grass for 6 months, the whole lot will just die. And that's a bit like the heart, only it happens over about 3 to 6 hours if the vessel's completely occluded. So that's where, if you're sitting there and you've got chest pain, usually that kind of first hour is where people sit, they'll have a bottle of Mylanta and try a few things. If that's happening, just come in. And people always feel silly if it's nothing, but you really don't need to. That's happy days. You go home and it's great. So if you're not sure, particularly if you're feeling pretty unwell, it's getting up in here a bit, it's like, I'd better go in and get it seen to. Yeah. Because then we see people quickly, and because we can action it very quickly, you come in quickly, you go straight to the cath, get it open. Gee, it's good. You see people the next day and they're totally fine, as opposed to when I started training 10 years ago, or 12 years ago, we saw a lot of people were really not very good. They'd sustain a lot of damage, they're shocked, really unwell, end up on lots of medications, the kind of stuff we were talking about. So the quicker you get in, the better if there's a big thing going on.
Is there a very good first aid training course you can recommend, Andrew, to do? I mean, that will obviously, if someone is having a heart attack, that we can.
So St John First Aid is kind of the big one.
Yeah.
You can learn how to do CPR on YouTube, and it's super easy. And the big change with CPR in the last sort of few years of the guidelines is what they found is that the whole mouth-to-mouth thing put people off because it's just a bit gross. And so they've moved to compression-only CPR now. So basically the message is, have a look at YouTube, consider a St John First Aid course, and if someone collapses, you just start doing CPR. So it's about 2 compressions per second across here. You're not going to make anything worse. If they've just had a faint and they wake up, they'll soon ask you to stop. And you will. We see people, we do see people not infrequently come in who survive out of hospital arrests, and it's a really amazing thing. Flip side is, of course, sometimes people will have really good CPR in the community and they don't survive, and that's nothing to do with the CPR they've received. It's just sometimes, again, the survival from that event is unfortunately not very good. But it's definitely a good idea to give it a go. You absolutely won't make anything worse. I remember being told when I was doing a first aid course as a student at school that you've got to listen and do this carefully, otherwise you'll make it worse, and wondering at the time how on earth you could make it worse, but it turns out you can't.
All right, well, thanks so much, Andrew. That's about all we have time for today. Thank you all for coming along and being part of our very special edition of Research Matters for World Heart Day. We want to thank Andrew very much for his time and taking the time out of your very busy schedule. We know from all of the amazing things that you do in Tasmania. As you know, the Foundation has an extensive history championing innovative research to create better health outcomes for Tasmanians. As you heard today, we fund research into heart disease and so many others, but we need the support of our community to keep funding projects like our amazing researchers like Andrew. So if you feel inspired by our discussion today, you can donate online at www.rhhresearchfoundation.org. Thanks so much for attending, and we look forward to seeing you all at an event again in the future.
Thank you. Thanks very much also as well, obviously, to the Research Foundation that's supported the chest pain clinic work, and also the Tasmanian Community Fund, who basically kicked us off back in 2014 with a grant as well. So it's very hard to get money out of the THS, as you can imagine, so we need some external support sometimes.
Excellent.